Subscribe to our YouTube channel and press the bell icon to get the latest updates.
How the global pandemic has crossed 5 million, and in India it's more than 1.5 lakhs. 4,300 cross deaths and so on. But I think the very important question is how we look at the preparedness, systemic preparedness, as well as immediate measures that both countries took and how to compare them. I think the distinct approach of both these scholars, and their publications have been circulated, especially ICS analysis number 100 by Madhurima Nandi on the latest situation, is to raise the immediate question with the systemic question and how both countries and the whole world can look at the health situation in an integrated way. So that is the subject of this afternoon's webinar. And we have some ground rules. This is a wonderful partnership with ThePrint. So we will, and this is live telecast on YouTube, and it will be put on the website also of both ThePrint and ICS. Friends, we have to strictly abide by the time limit. The 25-30 minute presentation by the two speakers, followed by questions by Jyoti Malhotra, the editor, National Affairs and Strategic Affairs, National and Strategic Affairs of ThePrint. Then we have two specially invited discussants who will take 2 to 3 minutes to comment. Professor Ramila West of the JNU Center for Social Medicine and Community Health, and Dr. Devaki Nambiar, Program Head, Health Systems and Equity at the George Institute of Global Health, New Delhi. And then we will have some 20-25 minutes of open discussion, questions. Please use the raise hand option under the the participants list under more, or through the chat box to ask your questions. So those are the ground rules, and we look forward to some exciting ideas coming from Professor Rama Baru and Dr. Madhurima Nandi. Now your turn, Rama.
Thank you, Professor Monty, and thank you, Mr. Ashok Kant, and all the colleagues at the Institute of Chinese Studies. Today, we will present some of our ideas and some reflections based on some empirical evidence as well as media reports. As the pandemic unfolds, health system preparedness in China and India. So initially, I just want to set the stage for the ideas around preparedness. Firstly, I think in human history, the COVID-19 pandemic has unleashed a shared global experience in terms of human experience, as well as health service system experiences. So if you look at reportage and writings from various parts of the globe, we do get a deep sense of uncertainties, fear, and anxieties. So this is a shared human experience. There is also the shared human experience of isolation and also loneliness. But in all of this, the human experience, which has been a shared one, has also been a story of the rise of hypernationalism. So what is a global pandemic? By definition is a global phenomena, but you also have state responses which have been, in a sense, framed by the idea of hypernationalism. And I'll elaborate on this a little later. What you also find is that this is an opportunity for great global cooperation and dialogue. But because of hypernationalist positions, you find disruption of global networks and a reconfiguration of the way in which global institutions are perceived and are being, in some cases, even criticized. But what are the commonalities we find when we say uncertainties about the human condition and the experience due to COVID, which we are all living through? But we also have uncertainties of science. So we have uncertainties in terms of understanding this novel virus, how it will behave, how it will mutate, and how it will interact with the human host. We also have lack of certain medical measures. We don't have the vaccine yet. We don't have medicines. Also, there's a lot of discussion and controversy around the hydroxychloroquine. It's certainly not for the purpose of treatment. And then when you have the moderate and severe cases, there's a very high reliance on tertiary hospital care. And this really involves preparedness of very high order, which is very labor intensive and also technology intensive, because you do rely on the need for intensive care units, you rely on isolation wards, you rely on ventilators and a whole host of other technologies. What this pandemic has also really brought out is the unequal distribution of the pandemic in terms of cases and mortality across economic and social classes, and therefore the vulnerabilities of race, age, class, caste, and gender. So what you're finding throughout the world, irrespective of which country you look at, whether they're highly developed or they are the low middle income or the middle income countries, is that the fault lines in the health service system have become rather glaring. And there is a great deal of variation in the levels of preparedness and the issue of public health governance. I now request Madhurima to continue.
Yeah, I'll just touch upon what went on in Wuhan, the time it started, the emergence of the pandemic, and the way it progressed over the next 2 months. One is, of course, to start with the urban context of epidemics. We know that most epidemics start in urban cities, and the challenges are much more there in urban context, with a high density of population and given the high number of people commuting and a high economic activities within a city. So the details of this epicenter and the Chinese response is what I'm looking at in the initial phases. So as of May, we have 97% of all deaths in China were concentrated in Wuhan, and about 80% of all cases were in Wuhan. So the initial delay in reporting these cases have been documented all across. Of course, even the leadership has acknowledged there was an initial delay. And in fact, we also, thanks to Dr. Hemant Adlakha for bringing up the Fang Wuhan diary in the last seminar, because we also were able to actually read it after that and look at what the details were. I mean, in fact, the Fang write-up gives a complete day-to-day unfolding of what happens on an everyday basis in the context of Wuhan, the pandemic, the frontline workers, how they are dealing with it, what happens with the hospital systems, what happens with daily livelihood. She talks about everyday lives of people, how it gets disrupted completely, what happens to people who are not COVID patients but are not able to access the institution. So it's kind of an unfolding of a pandemic of this scale, which has never happened before. And the fear is palpable. Like, you can read it through her diary, like the kind of fears, the small joys, you know, and every day, the deaths, which are initially distant but become closer home, people she knows. So all these things unravel over a period of time. And the interesting part is, like, what she says in one of the statements is when she's asked by the media person as to, you know, so what lessons has China learned from this? I mean, in fact, she responds back by saying it's not a lesson just for China, it's a lesson for the entire world, because as Rama said, the fault lines were quite clear. It emerged very starkly in the case of China and also for the rest of the world. In fact, in the epidemic preparedness, North America comes first in the rankings, but obviously it hasn't been able to live up to that. And we know the kind of difficulties people have faced all across, whether it's the institutions, the infrastructure, the daily lives of people, nurses, other frontline workers. It's all, I mean, it's been a sudden down of the systems that were actually or should have been in place. So in the case of Wuhan, we see that these similar things are happening, but since Wuhan was the first city to experience it, there's a lot of tension, panic, fear on an everyday basis. So in the sense, India at that time, of course, we have a lot of students from Kerala, almost 400 students from Kerala studying medicine there. In fact, last year, Rama and I had interviewed some of them who are studying medicine. And that was in the context of medical education in China and, what are their experiences there. So these were the students who were finally airlifted, brought back in January. And here we see that first cases come up in Kerala. And Kerala is, of course, an outlier for India, where you see the Kerala experience. Kerala kind of have entire month of February, they planned for it, for any future cases that came. They were able to initially stop the cases from increasing end of January. They were able to put their systems in place. They responded very actively. They had their local government response team ready. Even at the state level, they had a 25-member response team that was ready. So Kerala definitely had the plan in February itself, because they realized that there will be more cases that would come. And but in the sense, the whole of India, the central government, the national government seemed to have been quite unprepared and didn't expect the surge of cases that would be coming in the next 2 months. So, so the response by the Chinese government, then of course, once it's delayed and all, the response was swift. They tried to manage with their infrastructure. They called in human resources from other provinces. Almost 40,000 health workers came in from other provinces to help manage the pandemic. Of course, they went through a very severe lockdown, which was unprecedented. But probably now we see that most of the other countries have been responding in a similar way. And here we are, like we had the entire country put on a lockdown by March end. They also were the first ones to adopt certain protocols as social distancing, hand washing, and use of masks, which became like similar responses in other countries. So we had a lot of things to learn from Wuhan in that sense. So I will now request Rama to, move on with the Wuhan experience.
Yeah. Like Madhu said, I think Wuhan, in a sense, was the trendsetter. It became the model for most other countries to follow. And the logic of a lockdown was to slow transmission. As I had said earlier, there were really no medical measures. There was no treatment that was available. But it also gave ostensibly time to most governments to prepare their health systems to respond to the pandemic. And I think this is a very important aspect of it, and we'll come back to it later. What we are really looking at is, we're looking at hospital beds, we're looking at testing facilities, we're looking at ICU and isolation wards, ventilators, and other equipment. But the very important part of this whole story was human resource availability. It was a very labor-intensive, also an extremely exacting and fatiguing process for the doctors, nurses, and various levels of staff. But it was also a dangerous aspect. There were many safety issues involved. And in this, the personal protection equipment for health workers was a very important piece. The Chinese were able to increase, and in fact, when you read their response to the pandemic, they were able to increase supply of testing equipment. They were able to produce the PPEs required. That doesn't mean they didn't have shortages, because if you read the Fang diary, because of the virulent nature of the epidemic in Wuhan, they were just keeping up with the cases that were arriving in their hospitals. So it is not as if they did not face problems of PPEs. They also had to, and I don't know how many of you read reports of even building hospitals to be able to accommodate the sick. But yet there were these problems, there were these snags that they faced. But if you contrast it to the Indian experience, there is a glaring lack of preparedness in our case. Kerala being an outlier, I don't think that would be the norm. But if you look at the rest of the country, and this, like China, India is also, has several states and several levels of preparedness in health systems. But what we are really finding is the lockdown happens in the third week of March, but we are not using that time adequately to really prepare for our health systems. And another very important aspect of the preparedness was that we did not have self-sufficiency in medical technologies. We had to rely on imports. A simple thing like PPEs. You need cloth, which we had plenty of, but we didn't have the capital goods, which is a machinery to stitch PPEs. We had to rely on import of this equipment from China. And finally, we in fact went in for ordering PPEs from China, and there was a lot of delay in that process. So you really find that the preparedness is, like Dr. Mohanty said right in the beginning, is a systemic issue. So it is not just by increasing hospital beds or ensuring there are enough ventilators. If you have gaps in the system, then the efficiency of that system to respond to a crisis like this gets weakened. And you're seeing many stories in the Indian media around that, and I'm not going to get into those details. The other very important aspect that affected both China and India, and when you read Fang Fang's diary, you get a sense of this, is with COVID-19 on the rise and the hospitals being focused on care of COVID patients, the disruption of routine care. So if you suffered from morbidities which were not COVID, then you were postponed. Elective surgeries were postponed. People who were suffering from cancer, from kidney diseases could not go and get routine care. And this really was highlighted in the Indian context, where you have several reports in the media of people dying because they haven't had access to routine care. So whether it is diabetes or cardiovascular diseases, hypertension, cancers, they all require monitoring and treatment. Now, the COVID care overtook the health system in a sense, and the routine care was left wanting. Can we move to the next, Madhu?
Yeah. So we'll be looking, as Professor Mohanty and Rama have already said, like health systems, I mean, we have to look at it systemically. So we are looking at the building blocks of health system preparedness here. So you have financing, you have human resources, infrastructure, medical technology, and drugs. So I'll be talking about financing and human resources in a comparative perspective and look at how we fared and how China fared. So basically, I mean, if we look at the public expenditure on health, of course, I mean, that's the first thing that comes to our mind when we're looking at investing in health. We are still at just 1.2% of the GDP, and China is at 3%. So that itself speaks a lot. Of course, in various documents, India says that it will try to increase it to 2.5% of GDP by 2025, but it seems almost impossible that that's going to happen because ours has mostly been stagnant over the last 2 decades. So investment in human resources also shows a decrease in the Indian budget that has been detailed out after the union budget of 2020 that came out. So you have a lot of places where you've seen cutting of funds, like for nurses' education and nursing, building nursing capacity. But at the same time, you see the Chinese are increasing investments in human resources in all spheres, whether it's technicians, doctors, nurses, everywhere. The overall shortage of human resources in China and India is definitely marked by interstate and provincial variations. So you have a lot of cities that might be well funded with human resources, but not really the peripheries and the other parts of the district and smaller towns and rural areas. A primary level is something that has always been brought up as something that we need to build up, and that's similar is in the case of the Chinese context, because the primary level care has been part of their reforms for some time now. In the Indian context, if we look at human resources, we largely depend on the ASHAs, who are incentivized, but they are not part of the public health cadre. I mean, they're not part of the cadre per se, because they are not employees of the public sector. They're not seen as employees of the public sector. So, but in the Chinese context, you have a varied human resources across the primary level who are employees of the public sector. Also, to look at community level surveillance, the Indian health services depends much on the ASHAs. But the Chinese post-SARS have been actually systematically strengthening the primary level care. I mean, it's not like they've reached the perfect level of primary level care. I mean, of course, one of the reasons Wuhan the initial reports were about overwhelming public hospitals, because a lot of their care was still being taken care by the tertiary hospitals. So you see that the primary level care was not so well functioning in Wuhan, the way it is in probably Shanghai and Beijing. But they are in the process of mobilizing human resources at the primary level. And as we see, like they were able to mobilize and build their capacities during a pandemic. So increase in investments, I mean, during the pandemic, so there have been talks about what kind of post-pandemic measures and investments should be made, keeping in mind the context of the COVID and future pandemics that come. So the China definitely has gone ahead to announce that, you know, it's going to increase its investment in terms of surveillance, the primary healthcare. They have acknowledged what are their gaps and where they need to invest. But in the Indian context, the measures are definitely remain the same. Whatever Nirmala Sitharaman also said in the last week, in terms of the health, it's actually what we see is a repackaging of the earlier schemes. So nothing much that's coming out of it, apart from, of course, privatization has again been spoken about quite clearly, with public-private partnerships being brought in. So in the Chinese context, we see this, like they have, this is from the national work, their work report that came out, and Li Keqiang had spoken about a whole lot of things, but they clearly have spelled out like what they want to, how much they want to spend in the public budget on health. Then there's almost 1 trillion of government bonds for COVID-19 control, medical assistance for poverty-stricken populations, and they're increasing the health insurance subsidies, and also the per capita basic public health services. So in China, at least, we know that there is a basic public health service that's available. Of course, they have their challenges, but the basic public health services is available for 95% of its population. I'll now ask Rama to talk about the infrastructure and medical equipment technology and drugs. Yeah.
So what I want to really say is that, you know, when we read any report on COVID, everybody is waiting for the vaccine. And in this, there is clearly the play between what the earlier global networks were for scientific research, vaccine development, etc., and this hypernationalism. In a sense, this is getting played out in a very interesting way. I'll just deal with the infrastructure part of the story. In China, as you know from the Wuhan experience, they really did go all out to increase their infrastructure for hospital services. In the Indian context, public health systems or public hospitals were pretty much left to handle this issue. And even when we had an opportunity to requisition the private sector, we did not do so. Other countries like Spain, etc., have actually not only requisitioned, but they have nationalized private health systems, saying that this is an emergency, we need to rope in all the services that are available and has to be serving the public health good. So what you're really finding is, and if you look at Delhi today and the reports that are coming out, hospitals are turning back patients. They don't have beds. They are saying now you self-isolate, you take care of yourselves at home. And there have been deaths even when they required hospitals, they couldn't get hospital beds, or there was a shortage of ventilators. So even if you say the best efforts were made in the Indian context, they're still wanting. And if you look at states like Bihar and other states, it is even more abysmal. But I want to come back to the vaccine story a little bit. They're very
4 minutes, please.
Yeah, we don't have, we're not going to take too much time. But essentially, this also takes me to the last part of our presentation, which is to say that, globalization created networks for scientific research, for product development, and there were supply chains across the world, which did not, in a sense, honor these national boundaries per se. There were a lot of partnerships between US and Chinese labs, and even the discovery of, strengthening virology labs was part of the US mandate. And if you look at it, it's been going on for 30 years with the NIH actually giving grants to Chinese labs, training their middle and their, higher level scientists, etc. So suddenly when you have this hypernationalist narrative put onto it, it is like, so who is going to produce the vaccine? Is it going to be the US? Is it going to be China? Is it going to be India? So you have this narrative coming up. The testing kits is yet another story. Now we had to import testing kits from China. And then we said it wasn't good enough. But what is important in this is that we didn't have the capacity to produce the volumes that were needed for testing. I'm not saying we were going to become South Korea, but clearly we needed volumes and we couldn't do it. Similarly with PPE and drugs. I think we can move to the next slide. So this is really the last slide, and we both will be raising some of these issues and tying up some of the earlier issues. So we are looking at a new normal after the pandemic. And one of the things that Madhu said in her earlier presentation as far as India was concerned, this is true for China as well. There was a moment when you could say that for globally that you would have public health investments go up, public health systems re-strengthen, the reassertion of the importance of public health systems. However, it really varies across countries, but in most countries, you find that there is an effort to say that we will strengthen public systems. But at the same time, there is a reconfiguration of markets that are taking place. And this, I think, is very, very interesting and important, because when you look at China, there were reports saying that during this period of COVID, telemedicine was used in a large way in the Chinese hospitals for routine care. Immediately, all the consulting companies have come out with projections saying that telemedicine is going to be where you should be investing in the future. And if you listen to even the Indian context, a lot of the private hospitals have really been promoting telemedicine as consultations in time of COVID. The second very important aspect, which I think I'm not going to go into great length, is what is the future of global institutions and global cooperation? And I think in this case, the attack on the WHO is very significant. Almost as if WHO had all the powers to mandate countries. You see, one is to advise, one is to mandate, and if you don't follow, then to punish. WTO had that provisions, but WHO never did. And I think if you want to have global dialogue and cooperation, which I think is absolutely essential in a pandemic, then the role of global institutions cannot be fractured the way they have been, especially with the kind of position that the United States has taken in this matter. And one of the interesting things about the COVID-19 epidemic has been how doctors across borders have been talking to each other, because the uncertainties of the epidemic and the behavior of the virus has forced doctors to talk to each other. But when you put the hypernationalist narrative, then you find that nobody wants to talk to each other and everybody is out to other somebody else. So I think these are going to fundamentally change the way in which global institutions will I feel that will be weakened if hypernationalism takes over. The last 2 points, Madhu,
You can sum up those two.
Yeah. I'm just going to take a minute.
Yeah.
So basically, the last 2 points, we are looking at work and social relations. Of course, we have seen how this has also unfolded during the pandemic. The othering of a large section of the people. We have the migrants, the working class communities within cities who have been completely othered, and their livelihoods being snatched, their wages not coming in regularly. So the whole thing about social distancing itself, I mean, if we just put the social in quotes, I mean, it has taken a new meaning completely, because you really see a distancing at a different level. And lastly, just to raise a question is, I mean, this pandemic has really reinforced inequalities, along with what we see is breakdown of health systems, the reinforcing of inequalities at all levels. Thank you.
Thank you very much, Rama and Madhurima. I think the fault lines is the key word, and this presentation really followed so well the last ones by Hemant on Pang Pang diary, and both of you were quoting from the diary to make your points very well. And you concluded with the reinforcing of inequalities in this process. The point about the hypernationalism disrupting global cooperation possibilities, I think that was very important. We will have, and particularly the migrant labor issue, we couldn't discuss in detail. Maybe in the question hour, we'll come back. Thank you very much. And now, may I request Jyoti Malhotra to come and come up with her questions.
Thank you so much, Professor Nandi. Thank you so much, Rama and Madhurima. That was really interesting for me, because I don't look at these issues personally, but that was truly fascinating. My first question is your last line, Madhurima, where you said that the pandemic reinforces inequalities. And we've seen that so clearly in India, right? With the migrant workers, the way they've been treated. But what about in China? Not just the migrant workers issue, because that was, people were already in their cities after the Spring Festival. But how has the pandemic, or has it reinforced inequalities in China?
Yeah, this is definitely, even the Chinese context hasn't been any different. And what we see from Fang Fang's diary also is things are daily issues of this. Even if the migrants had gone back, bringing them back was a major issue. So a lot of them were actually losing wages. Also, a lot of discrimination against frontline workers, against people who are out for their daily work, those things were quite stark even in China, and that comes out very clearly in her diary. Also, there have been instances where you have similar instances of domestic violence. It's basically, if you look at class and gender, so these things have definitely had their impact even in China. So that really stands out. If Rama wants to add to it.
I think age has been an important issue, both in China, India, and globally. And the racial, not in the Chinese case, but in the US, the disproportionate number of deaths among the African American population, those who are poor. In fact, somebody asked the other day, do we really have data on the social background of the people who have died in India? We don't, because apparently they don't even record any other than the age and name of the person and the gender, but we don't get data on their socioeconomic background. We also know that the severe deaths happen in those who have comorbid conditions. So, who gets access to hospitals and who gets left out? And in Lombardy, it was very, very significant that doctors had to make this horrible choice about who will live and who will die. And I think this is something, that's why I said that the human experience part of the story really brings out some of these inequalities. in access, but we don't have hard evidence at the moment to say what is, to really talk about those inequalities.
Okay. You have more questions?
Yeah, just one more question from me, Professor Mohanty. The human experience that you talk about, Rama, now just a couple of days ago in the New York Times, the front page had a very moving article actually, which said that 100,000 losses due to the pandemic. And it was quite evocative because then you had the names of all these people who had died. Now, for a country like the US, and I'm sure, a lot of them are older people, and if they don't die today, perhaps they'll die whenever, soon enough. But, the hypernationalist narrative that you're talking about, I'm just wondering, we've seen Indian and Chinese soldiers facing off in Ladakh. You have a hypernationalist narrative that is being precipitated right now. You've seen this in the China-US comments between their leaderships. How is such a big crisis that we are confronting today, this pandemic? It's very difficult to resist a hypernationalist narrative, isn't it?
If you look at it from the human angle, you would say that what you actually need is cooperation. And the leaders may posture in this particular way, but like I said, the exchanges between scientists, between doctors, between the experience of treating, you see, how have we arrived at even understanding how to handle COVID patients? We don't have any other technology to deal with it. So we have learned a lot from the Wuhanese experience. But we've also learned from what happened, those countries that were a little ahead of the epidemic than we are. So, I think there has been a lot of free flow of exchange and ideas of how do we manage as doctors? How do we deal with fatigue in health workers? How do we make sure that they are safe? So there are a whole lot of questions around that there has been that cooperation, in a sense, people to people. But this hyper-nationalist agenda actually disrupts this.
But have we learned from China during the pandemic? Have doctors, Indian doctors and Chinese doctors, have they talked
absolutely.
to each other?
We have Indian scientists dialoguing with Chinese doctors, Chinese scientists. So this is what I said, that the world of science is highly globalized today. And there are enough studies to show us that this is not just begun now. The Sino-US was very, very much longer than the Indian-Chinese collaborations. But in the pharma industry, don't forget, we import generics from China. So this dependency, this global interlinkages in the world of health and science is something that is going to get disrupted with hypernationalism. And that's my greatest worry. So, you would say, all the RDT kits that came to us from China are all bad. They didn't work. Or the PPEs had to be dumped. But, there are reports today in the Indian media which tell you the PPEs that are stitched in India by all kinds of companies who are willing to do it are of very poor quality. So, I think we need to really sort of revisit how hypernationalism disrupts human relationship, which is why I kept thinking when we were reading the Fang Fang diary, is she was presenting the human condition. And if you read reports from the New Yorker, it's very similar. If you read reports in the Indian media, human interest stories, they're very similar. The plight of migrants, the scales are different. The depth of suffering may be different, but it has caused enormous human dislocation.
Okay.
Thank you so much.
Thank you very much. Let me also have the comment from Dr. Devaki Nambiar, please.
Thank you, Professor. Good afternoon, everyone. Thank you for this opportunity. I think a lot has been said, and what I'll try to do in my few minutes is just sort of reiterate some of the ideas and expand upon some of the ideas shared by Professor Baru and Dr. Nandi. And I have three of these fault lines, as Professor Mohanty has talked about. that I'd like to talk about. One has to do with the creation of infrastructure, new infrastructure. Another, as raised by one of the chat questions, has to do with traditional Chinese medicine and our traditional systems of medicine. And the third has to do with global cooperation in terms of expanding markets and meeting the requirements of public goods like vaccines. So let me get to it. There's a great article in The Lancet, which is a prominent public health journal, about the Fangsang shelter hospital. So this new kind of infrastructure that was created in the Chinese case. You see that in sharp distinction to what has happened in India, where we have just been displacing existing care. So Professor Baru pointed out how problematic that is. There have been PILs, there have been deaths attributed to this type of strategy. Where in the Chinese case, there was a real suspicion around the idea of home isolation. For a number of reasons, as this article points out. There is the challenge that of familial spread, the clustering of cases within families, the psychological problems that kind of home isolation may bring up. And finally, the argument was that it's very hard to enforce and act on home isolation. And so these Fangsang hospitals were set up. And certainly in the Indian case, you'll see similar kinds of challenges in cases where it has been isolation wards were created in government hospitals. You saw people fleeing them. You know, it was very problematic in the Indian case to try to create that kind of isolation in hospitals. I dare say that is not uniformly the case across the country. Here we can speak to Kerala's experience, where the home quarantine strategy is what was used actually, it worked quite well, at least in the first sort of set of cases that happened. You could say because of the Kerala-China Connect, they had a head start. You could also say there are many features of the Kerala health system that lend themselves by way of preparedness to be able to adopt a strategy like this. But it certainly has seems to have worked well in terms of controlling the spread of the pandemic so far. A couple of other pieces here. So there's no less than 15 million people that Kerala managed to keep in home quarantine as against the Fangsang strategy. A lot of this is attributed also to the relatively less stigma attached to being in home quarantine in Kerala. Some of this may have to do with the Nipah experience that the state had been through and the lessons that the state acquired along the way. There was extensive community participation, something like 100 contacts per trace, per person infected were followed up in the Kerala case, where nothing close to that has happened elsewhere in India. So the kind of follow-up that has been possible in this particular state has been notable, in contrast not just to China, but to the rest of the country as well. In the Chinese case, of course, there have been issues regarding consent and actually forced quarantine in the Fangsang quarantine hotel. So that's been a problem as well. And you know, it's hard to get a complete picture and full information about this. But from purely public health perspective, the Fangsang strategy has worked. Kerala's home quarantine strategy has also worked. So there you have it. In different contexts, these strategies have shown some success in these early phases. There is, however, a funding angle here as well in terms of preparedness and investment in infrastructure, as Professor Baru and Dr. Nandi also pointed out. You can see very clear pronouncements in China of their investments towards health. India is operating from a weak position here already, and it remains unclear, even as Dr. Bisht has pointed out, where in the stimulus package health stands, where in the PM CARES fund, for instance, health stands. We have $1.2 billion in that fund, and it's not clear what and how that contributes to health in particular. Concerns about the private sector also remain. Very quickly, I'll wrap up that point. I think it's useful and particularly important to look at the angle around traditional medicine. So the use of Chinese traditional medicine, specifically there's mention of something called Qingfei Paidu Tang, which I hope I'm not mispronouncing. This is actually, this preparation has shown promise in treatment of COVID-related symptoms. And this is according to the National Administration of the Traditional Chinese Medicine, and is also extensively documented in some papers and news articles. And there has been emphasis on also using Chinese traditional medicine as prophylaxis, and there has been rollout of this. In the Indian case, in March, there was an advisory put out by the Ayush Ministry. It didn't land well. Let's put it that way. There were a lot of questions raised about the basis for those recommendations and sort of the science behind them. But what has happened since has been quite encouraging. There has been a COVID task force set up by the Ayush Ministry. So the Ayush department has now become a ministry as of 2014 with its own funding and so on. And this task force actually has representation from different research councils in the country, which creates a very, I think, encouraging precedent in terms of being able to test different Ayush remedies and approaches.
Okay.
The emphasis in India, I should say, has largely been on prophylaxis, so prevention rather than treatment, which is historically also the case. So if you look at China and artemisinin for malaria, that was a treatment, whereas in India, we focus on yoga, prophylaxis, building immunity, those kinds of things. And this is also all over the news, things like East Delhi cops getting having Ayush supplementation and no cases arising and things like that. This really warrants further examination. And I think the creation of this task force has great potential. And I think hopes are high because there hasn't been much coming from that sector in India so far. Some of that is connected to structural reasons. The integration of Chinese traditional medicine is much better in China. Perhaps I'll hold off on my last point in the interest of moving ahead.
Those were very interesting points. Yeah. Now, from the chat list, let me just pick up 2 questions and then request Rama and Madhu to respond along with the other commentators. One is, who decides, who takes the critical decisions? Is it the medical professionals? Is it the bureaucrats? And how do you compare the 2 systems? Second, how reliable are the reporting processes? This has been raised in the case of US and both in China and India and other countries also. Then, of course, if you are reading Lin Hai, our friend Dr. Lin Hai from Shanghai, he says, don't take Fang Fang diary as a source of information. She's a writer with anger. Anyway, that was just to read it out. Otherwise, would you like to respond to some of these, please? Before I ask the people, Ambassador Goel and Ambassador Saurabh Kumar to come later with their questions. Yes, Rama and Madhu.
Yeah, this question of who decides, I think, is very critical, because if you look at the lockdown in India, the infectious diseases are in the concurrent list. So it is a central government, it's under the central government. But it has been a bureaucratic exercise. It has been a combination of the bureaucracy and the police to implement even the lockdown. And I think this has not gone well with many people, saying that you cannot control a pandemic without that. And there have been doctors who have said that their autonomy, their clinical judgment have not actually been consulted and factored in this decision. In the Chinese case, the moment the cases came out, it again came into the national jurisdiction. And it was a bureaucratic and an administrative exercise as well. So I think there is a very good expression which John McKinley uses, the proletarization of the physician. So in a sense, what has actually happened is, if you do, except the ICMR, now I don't want to get into that, the Indian Council of Medical Research has not really been in a consultative mode with, say, different state governments, different levels of expertise. And I think I do sense that there is a tension there. And, whose voice gets heard, whose voice then appeals to the national, the politicians, and how it gets used. So, there was a pathologist, a retired pathologist from NHS, who said that you cannot use bad science to do policies. And very often, bad science is used to do policies, because if you criticize or you question, then there comes an issue of, you're actually going against what people can do. And this reporting process is a huge problem, because again, I quote, I'm sorry I've forgotten the name of the pathologist, but I can share the paper. It was published in The Spectator. where he basically argues that, you know, the registration of the cause of death due to COVID is a tricky one, because you can register respiratory distress as a cause of death. You can register cardiovascular diseases as a cause of death. So do we really know how many are COVID deaths? Because you have to test the person positive, and then the person dies, then it gets registered as a COVID death. Otherwise, it could just be under any other category. So this process, this question applies across the globe. How reliable are your deaths? And most people would tell you that there is an underreporting of cases and deaths. What if you decide, I'm too scared, I'm not going to the hospital? Then you die at home, you get certified as, oh, he had a heart attack, and it's over. So I think there is this question of the reliability of reporting. And I want to bring back the hypernationalism issue. So you can actually suppress, I'm not talking about India or China, I'm talking about globally, you can suppress the number of deaths depending on how you do the count, and how much of it gets reported and how much of it goes unreported.
Okay. Ambassador Saurabh Kumar, please ask your question. Hello, Saurabh, can you hear me? No, then Ambassador Suresh Goyal, please.
Sorry.
Okay, Saurabh, please, yeah.
Thank you.
Yeah.
There was a power failure, so I've lost my, I put the question in.
Now we can see.
For both the presenters, very well done. I had a question about, you know, the question that we are not clear in the discourse, how in China, it did not spread to other parts, other major cities. Can that be addressed, please, to understand? Because 23rd January, when the lockdown in Wuhan and Hubei was imposed, and 27th December, the first case was documented. During this time, heavy traffic with other parts of China, but no spread. So of course, it was the initial phase, not many cases in Wuhan also, and so on. But taking it into account still, and considering the fact that the symptom period is said to be 2 weeks before. So, and according to another account, Mr. Lin Hai can bear us out, 8th December was the first appearance of symptoms. So during this long period of interaction, it didn't spread.
It's 16 hours.
Okay.
Sorry?
So let's take that question. Thank you.
Thank you. And related to that, sorry, if we...
I think one question is fine. You know, our time is very limited. Sorry.
By now, a day-to-day progression of number of cases, both in Wuhan and elsewhere, day-to-day from 27 December, because that helps in understanding.
Okay. Thank you. Now, Ambassador Suresh Goyal, please.
Thank you very much, Professor Mohanty, sir. Thank you.
Thank you.
I'm not going to start complimenting and all those things, waste of time. It was very good, of course. But come straight to the question to save time. That is basically the inequity between the private healthcare system and the public healthcare system. Is there such a phenomenon in China? Because what comes to my mind is that, like in India, if I have money, I would prefer to go to a private healthcare, a private hospital. Also linked to that is really the issue of access. The crowds which go to the public healthcare systems and have to wait for hours together to be able to see a doctor. So the access becomes a linked issue, and the issue of really the expatriate community. Now that China is part of the global trade links. So there is a huge expatriate community in China. Do they have equal access to this public healthcare system? Because in that case, they're depriving the Chinese natives of the same facilities. How do they deal with the healthcare then? Thank you, sir.
Thank you. Now let me add 2 questions from the chat box. Dr. Nina Verma says that she disagrees that lockdown hasn't helped. Actually, nobody said it hasn't helped. It has helped in India. But she points out how, in this 2 month period, there has been expansion of the production of kits. Now we have 600 plus laboratories testing, more than 1 lakh tests per day, and so on. So, it has had a lot of positive effects. She says that this should be recognized. Now, Govind Kelkar has two questions. One is, she wants to know the reaction of the youth in both the countries to all these measures. And second, what was the impact on the gig economy workers, particularly women gig economy workers? So women in the gig economies. Now you can take up all these four.
I will answer the first one first, Ambassador Saurabh Kumar's question. So I have some data which says that this is, of course, I'm just assuming a lot of things here, but it says, like what I'd written in my ICS analysis also, that there were about 375 cases in Hubei before the lockdown, and about 571 cases in entire China before the lockdown. Also, the 5 million people who left Wuhan city before the lockdown were actually the migrants who were going, in fact, to different parts of Hubei itself. So about 70% of the 5 million people were actually migrants who were from the Hubei province itself. And that's the reason probably later you see, like by early February, Hubei is also under a lockdown. Initially it was Wuhan city, and then you have the entire Hubei under lockdown. The other thing is, of course, I feel that in other cities too, even though the lockdown wasn't so severe, things had come to a halt. In a sense, the surveillance measures and all were all in place, were obviously brought into action. And also the hospitals were asked to prepare. In fact, Lin Hai will be able to say, because we were in touch with him when he was in Shanghai, and they were all already under a lockdown. It's not like they were functioning from their offices and all. So things had stalled immediately after the Wuhan lockdown happened. So in that sense, I feel the cases they were able to handle. And the SARS experience itself had given China it was kind of a red flag to them again, because this was something again they were facing, and this was a new kind of coronavirus. This was a new, the whole thing about uncertainty, the whole thing unraveling. So China was on alert. Immediately that it happened, they didn't want to repeat the same mistakes that they had done before. So I would attribute the less cases to that, in the sense, of course, some of these cases then go off to some of these people go off to Italy and travel there, and things go completely spill over. But of course, that's also because the preparedness was much less in these countries, and they didn't take it so seriously the way China had taken from the initial case itself. From the moment they learned that human-to-human transmission was, they acknowledged the fact that there was a human-to-human transmission, they went into complete mode of, trying to handle this at the primary level and surveillance mode. The next, Rama, would you want to take up the private health sector?
As far as the private, there is a large private sector in China. And in fact, because of the social insurance, it covers mainly public hospitals. But recently, the Chinese have allowed some private hospitals to come in certain provinces to access the social insurance. Expats access private hospitals. And in fact, there's a very interesting history of how it was an American woman who sets up the United Family Hospitals, a chain of hospitals in China, and mainly for the expats. But now, of course, the Chinese also access it by paying. So you have the rich Chinese who access these private hospitals. But public hospitals in China are as crowded as the ones in India. The volume of patients is very high. There are long waiting lists. So all those questions of how do public hospitals function and are they able to cope with the kind of patient load they have are important questions. And partly this is due to the fact that the primary level of care is not as strong. So in fact, if you look at patient behavior in China, Chinese go straight to hospitals rather than to the community health centers. And this is a huge challenge for the Chinese. If you're interested, you and I have authored a book on commercialization, which gives a lot of these details. So you have a commercialized public hospital, you also have a large private sector, and the private sector does get government subsidies. So, they coexist. And in the time of COVID, like Ramila pointed out in her comments, they did requisition the private sector for COVID cases.
Right. Do you have on the impact on women in the gig economy? Any comment on that?
Well, I'm not so sure about that, but the impact on youth, what isolation did to families, I mean, I think we know what it is in the Indian case. And again, I'll refer back to the Fang Fang diary to really look at what people felt. And in fact, the motivation for Fang Fang to do the diary was a catharsis. She says, I had to vent what I was seeing and feeling, and the sense of despair and depression, So I think this is again a globally shared experience, because if you read from other countries, especially the elderly, this sense of deep loneliness and not knowing what's going to happen to your life, and your entire normal routines being, broken. I just want to respond to Nina Verma's comment on the lockdown. You see, when we said that yes, we needed a lockdown, but I think I don't want to get into the debate here. What kind of a lockdown did we need? For what purpose did we do such a severe lockdown, which produced so much of economic displacement? There are other countries which have tried middle paths. I also want to point out that all the data that you're telling me about PPEs, etc., is much later than April. The question I'm asking is, if the first cases of COVID came into India end of January, early February, what were we doing for 2 months? Did we just not believe that this was going to hit us? Didn't we learn from the way in which the pandemic went to other continents? So my point is that we lost some 2 months' time of even taking an assessment of what is it that we would require and how are we going to deal with it. So I mean, I'm not saying that we didn't catch up, but the question of quality is still very important, including our testing kits. And if you read people from ICMR and follow what they are saying, we are dealing with a lot of false negative cases and false positives. So I think, yesterday we heard Deena Das on a webinar, and I really want to quote what she said, and I agree with her. She said, only if the scientific community told us there are uncertainties, that they don't have all the final answers. If our politicians accepted that there are uncertainties, maybe it would be the ground on which you build trust with people. But if you say that there are certainties, and when you're in the midst of uncertainty, I think that's real falsehood.
I think that's a good point to conclude. I will just add a reference to the political report of Lekha Chang, Premier. We now know that they had 5 special groups at the center. The party, one general group led by Xi Jinping, then the lead group, the party lead group headed by the Premier, that means the state organization. Then they had 2 technical groups, a professional bureaucratic group and a professional group where bureaucrats, politicians, party leaders, as well as doctors were there. And then the center-province-city relations, there are just 2 sentences in the report which showed how they tried, to build this coordination between the 3 levels. In other words, in China too, the coordination is so important. And the real work is done at the ground level, at the city level, the town level. I think so this is one. Then I still notice that in the COVID paragraph, the health paragraph, the emphasis is on increasing the insurance assistance. You did mention that their primary healthcare system is getting strengthened day by day, but I fear that that is still not the highest priority. And you indicated that in your book on commercialization. I think if one message we learn from COVID in both the countries and throughout the world, I think the primary health center at the village level, township level, town level, with good expertise, good financial and medical support and personnel support is what is very important. And that is possible only when the economic and social conditions also support that. Thank you all very much for an excellent discussion. And thank you, Ashok, for arranging it. Thank you, Jyoti, for raising those interesting questions. Thank you all very much for your interesting questions. Thank you.
Thank you. Thank you, everyone.